All right, let's dive into something a bit different today. We're going to simulate a full-blown general surgery oral exam. I'll be playing both the examiner and the candidate to walk you through a really classic case, anal squamous cell carcinoma. Now, this isn't just about memorizing facts. It's about learning the structured, step-by-step clinical reasoning you absolutely need to pass these high-stakes consultant exams. Let's get started. I think this quote just perfectly captures the spirit of these exams. They're designed to push you way beyond your comfort zone, to really prove you've mastered the material. This case is definitely going to challenge us to think on our feet and stay systematic, even under pressure. So here's our roadmap. We're going to follow the entire patient journey, right from the initial presentation and diagnosis, all the way through to the management plan, the follow-up, and you can bet there'll be a few challenging twists at the end. Okay, let's get serious. My demeanor is changing. I am now the examiner. Let the viva begin. Good morning, candidate. We have a case for you. A 45-year-old female patient has come into your colorectal clinic. Her complaint is an anal mass that she's noticed for the last 3 months. Tell me, how will you approach this patient? Shifts to a measured, thoughtful candidate tone. Thank you, sir. I'll approach this patient systematically, as always. I'll start with a very thorough history and then a focused physical examination. Really, my goal here is to build a solid list of differential diagnoses that will then guide my next steps and investigations. So digging into the history, I'd first want to really understand the mass itself. She confirms it's been getting bigger over the 3 months, and it's also itchy. But here's the first major red flag. She's reporting pain and swelling in her groin. That immediately makes me think about lymph node involvement, a sign the cancer might have spread. She denies other things like rectal bleeding. Then, when we get to the social history, 2 huge risk factors pop up. She's a smoker, and she mentions her ex-husband was diagnosed with HPV. Both of those have a very strong link to anal squamous cell carcinoma. For the physical examination, of course, after ensuring privacy and getting consent, I'd begin. Her vitals are fine, her abdomen is normal. The really crucial part starts with the groin exam. And just as she said, I can feel multiple palpable lymph nodes in her right inguinal area. This confirms my suspicion from the history. Then on the digital rectal exam, I find a hard, fungating mass. And by fungating, I mean it's ulcerated, growing outwards. It feels aggressive. It's about 3 by 4 centimeters, located just below the dentate line, which is that key landmark in the anal canal. The hard, fixed feeling of this mass is really suggestive of a malignancy. Very good. You've identified the key features. Let's move on. Based on everything you've found so far, what is your differential diagnosis? Well, sir, with this specific combination of findings, a hard, growing mass, those palpable groin nodes, and the major risk factors, my #1 diagnosis has to be anal cancer, specifically squamous cell carcinoma. Of course, I'd keep other things in mind, like maybe a large condyloma or even thrombosed hemorrhoids, but given the hard texture of this mass, they are much less likely. My primary concern here is absolutely malignancy, and that's what I have to rule out first. All right. And how will you investigate to confirm your suspicion? My investigation will have 3 key steps. First, I'd get baseline bloods, a full blood count, liver function tests. Second, and this is a classic exam point, I will perform a full colonoscopy. Even though we can see a lesion in the anus, it's absolutely crucial to check the entire colon to make sure there isn't another separate cancer hiding further up. And third, the most important step for diagnosis, I will take an incisional biopsy from the anal lesion itself. I'd likely do this under general anesthesia to make sure the patient is comfortable and I can get a good, deep tissue sample for the pathologist. Excellent. The biopsy comes back. It confirms moderate differentiated squamous cell carcinoma. Okay, so now you have a confirmed diagnosis of cancer. The next steps are absolutely critical. Your thinking needs to immediately shift from just diagnosis to a full staging and management plan. This is a key test of your safety and your judgment as a candidate. So you have a confirmed diagnosis of anal SCC. How will you manage this patient? Sir, my management will be very systematic. Now that the diagnosis is confirmed, my immediate priority is not treatment, it's staging. Staging is absolutely paramount because we have to know the full extent of the disease before we make any plan. So that means a CT scan of the chest, abdomen, and pelvis, what we call a CT cap, to look for any distant spread, and a pelvic MRI to get a really detailed map of the local tumor. Only after all that staging is complete, the case must be discussed in our multidisciplinary team meeting, or MDT. Once we have a consensus, the definitive management for this localized anal SCC would be chemoradiotherapy, which is known as the Negro protocol. And importantly, the radiation field will be extended to cover the groin because of those positive nodes we found. You mentioned the Negro protocol. Tell me more. Explain this cornerstone treatment and why it is so important. Of course, the Negro protocol is the gold standard of care for non-metastatic anal SCC. It's what we call concurrent chemoradiation. It combines chemotherapy drugs, typically 5-fluorouracil and mitomycin, with external beam radiation at the same time. You see, its development was truly revolutionary because it completely shifted the treatment paradigm away from radical surgery. The whole point of the Negro protocol is to cure the cancer while preserving the anal sphincter. This means we can avoid giving the patient a permanent colostomy, which is just a massive win for their quality of life. And sir, a crucial distinction, especially for exams, is how we manage anal SCC versus anal adenocarcinoma. For SCC, as we've said, chemoradiation comes first. Surgery is only reserved for salvage if the disease comes back or doesn't go away. But for adenocarcinoma of the anal canal, it's the complete opposite. Radical surgery and abdomoperineal resection, or APR, is the primary treatment, and chemoradiation is often used as an add-on or adjuvant therapy. Showing you understand this difference demonstrates a much deeper grasp of the topic. A very important distinction. Well done. Now, let's assume the patient completes the Negro protocol and has a good clinical response. The treatment is over, but your job isn't. Let's discuss follow-up. Right. Post-treatment surveillance is critical for catching any recurrence early. My protocol would involve a clinical review every 3 to 6 months for the first 5 years. At every single one of those visits, I would perform a digital rectal exam, an anoscopy to get a direct look at the original tumor site, and a very thorough inguinal examination. On top of that, I would arrange for annual CT scans of the chest, abdomen, and pelvis to keep an eye out for any distant disease. All right, now for a new scenario. 2 years into follow-up, you find a small, hard nodule right at the original tumor site. A biopsy confirms it's recurrent SCC. What will you do now? In a case of local recurrence after chemoradiation, the first and most vital step is always to restage the patient. I'd order a full workup, probably including a PET CT scan, to be absolutely sure there's no distant metastatic disease. If we confirm the recurrence is isolated just to that local spot, the case goes straight back to the MDT for discussion. The standard of care at this point is salvage surgery, which means an abdominoperineal resection. This is a very major operation where we remove the anus and rectum, and it does result in a permanent colostomy. I see. Let's change the scenario one last time. The local exam remains clear, everything feels fine. However, on her annual surveillance CT scan, the radiologist calls you. They found a new, solitary 2-centimeter lesion in segment VI of the liver, and it looks suspicious for a metastasis. What will you do now? This is a very significant development. It represents what we call oligometastatic disease, meaning the cancer has spread, but only to a limited number of sites. My approach here has to be aggressive and completely multidisciplinary. First, I would discuss the case urgently in our MDT, but this time, making sure our specialist hepatobiliary or HPB surgeons are there. Second, a PET scan becomes essential to confirm this is truly a solitary metastasis with no other hidden disease anywhere else. Third, she must be referred back to medical oncology to consider systemic chemotherapy. And fourth, I would urgently refer her to that HPB surgical team to see if they can either resect or ablate that single liver metastasis. For a select group of patients like this, with isolated metastases, an aggressive, multi-pronged approach combining both systemic and local treatments can still offer a chance for long-term survival. But it absolutely requires a highly coordinated expert team effort.